Thanks very much, Chris, and thanks to everyone for having me here tonight. Can you just confirm that you can hear me, please, and then I'll start.
Hi, Paul. We can hear you, but you did cut out intermittently. Mandy, I'm not sure what you were hearing on your side. Can you check?
Oh, sorry, it looks like it's my internet. Let me continue. Please just jump in if you lose me so that I know.
Okay, cool. I will do.
Seems to be all right.
Right, so let's get started then.
Okay.
Okay, I'll get going then. So once again, thanks for having me. And as Chris has mentioned, we'll be looking at special investigations related to the COVID patient. So that would be the suspected or confirmed patient, and hopefully scrutinizing a bit closer the rational or insightful use of those special investigations. I'd ask you just to bear with me, please, at certain times. It's the first time I've done a presentation through such a platform. I'm used to a more interactive and personal type of presentation, but here we go. So, why do we perform special investigations? Well, there's various reasons, and that includes working up the patient, trying to delineate a specific diagnosis, also to narrow down a differential, to assess if we have come to a specific diagnosis as our likely cause, the severity or the complications related to that possible illness. Prognosticating, so do we think that this patient is likely to experience a severe or mild course of the illness? And then that therefore affects our management of disposition. Are we going to prescribe certain treatment potentially? Do we want to admit them? Do we want to discharge them, etc.? It's also useful in monitoring efficacy of treatment or monitoring disease progression. That's more often for inpatients, but if we do see follow-ups within the ED, that can also be useful in certain instances. Surveillance, so I put that in brackets. That's obviously playing a large part of what we're doing right now regarding testing for COVID. And in normal circumstances, disease with a potentially mild course, we wouldn't necessarily pursue endlessly. For the purposes of public health, we're obviously testing all of these patients. I've also put in-hospital in brackets because sometimes what our in-hospital colleagues would like as part of their admission package differs somewhat from what we find useful in the ED, but certainly to maintain relationships, we're more than happy to assist and request those investigations on their behalf when admitting a patient. And then lastly, screening, which is really something we hardly ever do in the ED, and I separate that from surveillance in this particular instance. So those are really the main times or the main reasons why we would want to perform special investigations. It is important that before ordering any special investigation, we ask ourselves several questions. And when that really comes down to is the result of this patient, of this investigation, going to change what I'm going to do for this patient in any way? Because if the answer is no, we really need to think twice about pursuing that particular investigation. What we really need to keep in mind, and it's really one of the primary things I'd like you to take note of from today's talk, is that if there's no potential positive impact on the patient, is this something that we should be doing or asking for? We're all inclined to have this mentality of action is better than doing nothing, and to act now rather than waiting and seeing. And that's not only us as healthcare providers, but patients put far too much emphasis on doing something as being good and not doing something as being bad. And I think we need to try and change that mindset and find the right type of balance. And that balance can be found between several different factors. I'm just going to quickly bring up a few of them now. It's finding the right balance between the benefits or the potential benefits of a particular investigation or treatment. I'll touch on treatment a little bit today, but that's not the focus. And their potential risks. And that's risks not only for us as providers, because often medico-legal jumps to mind, oh, I don't want to miss that particular disease, a possible PE or possible MI. Imagine what could happen to me medico-legally. What's really more important, although that is a consideration, is the risks to the patient. And as we'll look at just now, all tests inherently have risks in them. So it's finding that right balance. Balance between the clinical utility of an investigation versus the safety net that we want to try and provide for ourselves. Of once again, I don't want to miss anything. I don't want to take too much of a risk in not identifying a particular entity. Let's over-test, potentially. Don't see it as over-testing at the time, and cast your net very wide. I've already touched on that acting now versus that very intentional active inactivity. may be referred to conservative care, watchful waiting. It's got different terms, but knowing that action or doing something isn't always the best. And just in light of all this new evidence that's coming about during this time of COVID, it's finding the right balance of how we utilize this new evidence, of not adopting too early and wanting to seem to be at the forefront at all times of this new evidence, incorporating things that really don't have great evidence backing it up. Or on the other extreme, a nihilist who really is quite fixed in their ways and doesn't want to take up any new or consider any changes regarding their care or management of patients. So all of this is a law. So I don't know if any of you watching recognizes this particular individual. His name's Ken Milne. Quite a well-known Canadian EM physician in the realm of EB medicine or evidence-based medicine, and he runs a great website and podcast called The Skeptic's Guide to Emergency Medicine. In that podcast, he has a little section called Time to Talk a Little Nerdy. So please excuse me for the next 5 to 10 minutes. We are going to, maybe not the wisest thing to do at 6 o'clock on a Thursday evening, and I'll try and keep it as simple as possible. But I do think gaining a bit of insight into the mechanisms behind these things that we quote, like sensitivities, specificities, etc., will aid us in making good decisions when choosing on special investigations. And that's in general, not just in COVID. We'll be just covering a couple of different topics under that. Yeah, Chris?
Sorry to interrupt. We did lose a little bit of sound in between. I'll just keep an eye on it. And I'm not sure there's any more you can do, but just to see on your side if there's any on your connection that you can do. We got most of it.
Let me quickly check.
It did cut out intermittently.
Okay, sorry. Let me know. Message me on my phone. We'll try and have a look at that.
Okay.
Cool. Sorry about that.
I think if you stay
I'll just carry on. Sorry, I don't want to. Sorry, what's that, Mandy?
I think if you stay close to your speaker and not move around too much, that seems to be better. Okay,
I'm using headphones. I think it might be my internet.
Okay. All right. Well, nothing.
Okay. Sorry about that. Let's watch it though. Let me know if it's persistent.
That's perfect. Thank you.
Okay, cool. Sorry about that. We'll carry on, but it's just that we're going to cover a couple of nerdy things, and I hope it's not too overwhelming for those of you that don't find it too interesting. But it will hopefully provide some insight when we're deciding on which test to utilize within the ED. So the first concept is that of the perfect test, and recognizing that there's no such thing as a perfect test, and there are various reasons for that. The one is that every test inherently has a process to it. And anywhere along that process, error can creep in, and that can be human related, it can be machine related, etc. There are also, as we mentioned before, risks and limitations associated with any test. And the risk for myself might be a bit different to the risk that someone else experiences when undergoing that same investigation. There's also patient preference and tolerability. So someone may not like having their blood taken, and that would then preclude you from now investigating through blood tests potentially. It's just an example. An MRI is another one, someone who's claustrophobic, and you might have to work around that. It's also quality of evidence. The test is only as good as the evidence is based on, and just as there's no perfect test, there's no perfect evidence. We're hopefully making use of the best evidence available at the time, but there's no guarantee to that. And a lot of this does warrant scrutiny, if not by ourselves, from at least people we can trust and then look to for advice. So that's the first concept. There's no perfect tests, and no test is infallible. And what I touched on earlier is that patient-centeredness really should be our primary objective. And a lot of the trials that are conducted looking at the reliability and accuracy, etc., of investigations don't often include the continued pathway or care pathway. So in other words, extending to treatment or patient-oriented outcomes. And that's really what our ultimate goal is. And so that's what POO stands for, is patient-oriented outcomes. And we should always keep that ideal in mind. It's quality of evidence. So once again, we've seen a lot of variable evidence coming to the fore during COVID now. And it's that quality of evidence that creates the foundations on which we rely when deciding on what tests to perform, how to interpret them, what they might mean for the patient, etc. And that obviously extends to treatment also, not just investigations. It does mean, once again, that scrutiny is often warranted, because if we don't look closely enough and look deeper than the surface, we really may be relying on things that are far too rickety or far too unsound. And we've seen that happen numerous times already during this COVID pandemic. Hydroxychloroquine being a prime example. So just as there's no perfect treatment, so there's no perfect test, there's also no perfect treatment for the exact same reasons as there's no perfect test. There's no one size fits all. An antibiotic that may cure me with a bacterial pneumonia might not cure my neighbor. Someone may benefit from conservative management of a fracture, someone else may benefit from surgical intervention, etc. Once again, it comes down to tolerability and patient preference, as well as the various risks, etc., that are often innate in these various forms of treatment. And cost is also a consideration. It's not the primary concern, but it should definitely be considered when investigating and treating patients. And then it also comes down to the quality of evidence on which it's based. Just very quickly, so sensitivity and specificity are terms that are being thrown around quite a lot at the moment. I'm sure we were all exposed to them during our varsity days. Sensitivity really means how good is the test at identifying those patients that really are positive. Another way of saying it is how many false negatives will be. Specificity is how good is the test at identifying those that really don't have the illness? Or looking at it from the opposite side of the coin, how many false positives will we get? This is a common memory aid, snout and spin, that a good sensitivity is nice to rule out, and a good specificity, is nice to rule in. It's a nice way to remember them. Unfortunately, it's not as clear-cut as that, and we're going to have a closer look at that shortly. There are limitations to these concepts of sensitivity and specificity. I keep on alluding to it. They're only as good as the evidence they're based on. And when things are rushed, the evidence is often questionable. They rely on a gold standard, and that's what they're compared to. And that's one of the primary reasons we have such a problem with our COVID testing, is that the swabs themselves are the gold standard. So what do we compare them to? And we'll touch on that when we talk specifically about the swabs. We don't always have the gold standard available in the ED, firstly. It might not always be timeliest intervention for us to consider. And the gold standard itself, like in the instance of COVID, might not be that great. One very important concept, and it's a bit hard to really illustrate it, is that these are test characteristics, and context is important. So why is context important? Because we really do need to see the whole picture to understand what's going on. It's like when you bake a cake, the various ingredients go in and they work together to form the end product. And when we're testing a patient, it's the test itself and the patient that are coming together as ingredients. So they're both going to have an impact on the final outcome or result. It's not just the test as an ingredient. And that's really why context is so important. Another reason context is important right now is the possible disaster scenario. We've already been through it up in Joburg. It seems like we're starting to wane. Whether or not that will be persistent or not, we don't know. But this could represent maybe a typical day in the ED. It's fairly busy, but given our environment, working in a private ED, we can access the various tests that we want to usually, and most of the time we can escalate treatment if we think it's warranted. And there's no real problem in accessing those resources. In a disaster, however, that's different. We might not be able to access the test as readily as we wanted, for instance, a CT, for numerous reasons, which we might touch on. We might not be able to escalate that care, or that treatment rather, because care we would never de-escalate. We might not be able to escalate that treatment like we wanted to. So for instance, accessing critical care or mechanical ventilation. And that may have an impact then on how we choose to work up the patient. And we'll see why now. So let's take a closer look. Excuse my lack of imagination with this, but let's just say that there's a disease A with a prevalence of 1 in 1,000 people. And there's a new test that's come to the fore, specificity of 99% and sensitivity of 94%. And you decide to do this test on a patient in your ED, and it comes back positive. Now the patient's very concerned. They said, oh, you told me it was 99% specific. Does that mean I have the disease? And it's really what it means. Like we said, we need to take context into account. We need to look at all the ingredients from the end result. So what do I mean by context? What that really is the prevalence or the pretest probability. And we're going to come back in a second to that example that we started on. prevalence and pretest probability, it's normally a mixture of both objective and subjective things. There are certain clinical quantified pretest probability for us, like the Wells, for instance, in PE, or the HART score in ACS. More often than not, though, we are innately performing
Hi, Paul, are you still there?
Yeah, Paul, we're losing you.
Within our minds. And sorry, give me 1 second then. Sorry. Okay, I'm coming back right now. Okay, great. Let me share again. Sorry, I think it's my internet.
Cool. All right.
Okay. So where did I lose you? Where did you lose me?
On the section where you were looking at
The example.
That's it. Yeah.
Okay,
yeah.
cool. So just very quickly, we've got a disease A with a prevalence of 1 in 1,000 and the indices as shown there, a sensitivity of 94 and a specificity of 99%. You get back a positive test result in this patient, and she now asks you, does that mean I'm positive? Do I have the disease? As you told me, it was 99% specific. So in a second, we're going to delve into that and see why that's not actually the case. So I've been mentioning context quite a bit in the last few slides, and what do I mean by that? What I'm really referring to is prevalence or pretest probability. And that's normally a mixture of both objective and subjective criteria. And there are certain decision tools like the Wells or the HART score that try and quantify those pretest probabilities for us. But more often than not, we are innately calculating such likelihoods in our own minds by putting together various clinical information. It is population-based, and that population can be any population. It can be the community in which you live. It can be the type of person that you are, and anyone else that may meet similar standards or definition depending on what we're looking at. So someone who's hypertensive, someone who's diabetic, someone who has a tachycardia, etc. It is based on demographics because that may predispose to certain risk factors. What's also important with demographics is the prevalence within the community of that particular illness or disease. Already mentioned risk factors, and then clinical signs and clinical judgment, and perhaps even other results that have already been revealed. We put this all together in a soup, and we then come up with an idea of how likely we think a particular illness or disease is, or injury, to be present. So coming back to our example then, now knowing what I mean by context, let's just say this is our population of 1,000 people. We said there's a prevalence of 1 in 1,000, so there's our positive patient. Obviously, in real life, we don't know who the positive patient is. We just know that there's a prevalence of 1 in 1,000, but we don't know who that individual is. We said there's a specificity of 99%. So specificity was how good is that test at identifying people that really don't have it? Or another way of thinking about it is how many false positives are we going to get? That would be the opposite side of it. So with a specificity of 99%, we're saying that we're going to get a 1% false positive rate. So in other words, everyone that's negative, out of all of them, 1% of them will test positive. So if we have a population of 1,000 and one's positive, we have 999 that are negative. 1% of 999 is roughly 10. So if we consider our population as a whole and we tested everyone, we'd get 10 positive test results back. 11, excuse me. 11 positive test results back. So what is actually the likelihood that the patient of ours really is a true positive and not a false positive, like we're seeing here? It's really 1 in 11, which equates to about 9%, which is some way off the 99% specificity. And that's where we really need to remember that the specificity and sensitivity are test characteristics. When making that cake, we need to take into account all of the ingredients that go in and produce that final product. And here the patient characteristics are important, or the context. We'll touch on negative and positive predictive values, but if you just do the maths in your head, if the prevalence were to go up, so the number of true positives were to go up, the positive predictive value also increases, and we'll touch on that. Just to use a real world example to maybe illustrate it a bit better, would be a urine dipstick for pregnancy. And we know that they're pretty good regarding specificity and sensitivity. And let's just say one was processed by a very eager nurse on a urine sample that was left in the sluice room. Transpires that the test is positive, but when they actually take it back to the patient, it's a male patient. We've just said that they have a very good specificity. Is it more likely that it was a false positive, or is it more likely that there's a pregnancy in this male patient? Of course, in this day and age with gender reassignment, it's not an absolute impossibility, but it's a very significant unlikely scenario. So despite a very good sensitivity and specificity, there was still a false positive in that test based on the prevalence of pregnancy in males. This is just showing how we probably conceptualize likelihoods or the probability of certain illness. We don't really assign a number to it in our heads. We just think it's very likely, it's probably quite likely, or it's very unlikely. We give it some sort of degree qualitatively. Just very quickly, I'll go over this. It's just a way to show this graphically, and maybe for some people it will just help the understanding, because to conceptualize numbers isn't always so easy. So what a leaf plot does is sorry, can you see my mouse moving? Chris, if you wouldn't mind just answering me, does my mouse come on the screen?
Yeah, I can see it perfectly.
Okay, great, cool. So what a leaf plot does, just very quickly, is it plots the sensitivity and the specificity. So this arc with its shading here represents the specificity, and that arc there with its red shading represents the sensitivity. And this diagonal across here is your starting likelihood of disease. And once again, it's assigned a percentage because it is a stat. But in real life, we're really assigning a more qualitative descriptor to it. So it's maybe very likely, it's quite likely, it's not so likely. So you start somewhere there, you then perform the test, and if the test is positive, you go up to the positive one. And if your pre-test was 0.5, your post-test after the positive is now at about 65%. Likewise, the opposite is true if they test negative. You then go down to the negative arc over here. So the post-test probability is now about 25%. And you can see here, they're quite narrow arcs. They really hug that diagonal line when the sensitivity and specificity aren't great. However, when the sensitivity is good, we've said that sensitivity is good at ruling out. And you can see that arc is now big. There's a real change from pre-test to post-test probability that we're going to find when performing this test. And then here, the specificity, that we see a significant change of when the specificity is high as a rule-in test. For anyone that is interested, this is a nice website where you can actually download a tool to plug in a sensitivity and a specificity, and it creates a chart like this for you in Excel. Just very quickly to highlight one or two things, and then we're going to move on quite soon. And that's regarding risk. And risk is inherent in everything that we do. And there was a very interesting study that looked at how happy different levels of healthcare provider are regarding risk, or what they find is acceptable risk. And not surprisingly, the more experienced providers are actually more ready to accept missing certain things, and realizing that there is inherent risk in what we do as healthcare providers, whereas those who are less experienced are far more concerned about missing possible diagnoses. The next question then is, what do we consider an acceptable risk? So in other words, what do we consider an acceptable miss rate? And we'll touch on things that might affect that or influence that question. But if we just quickly use this example of D-dimers in pulmonary embolus, which is quite pertinent because we'll be looking at that in detail regarding COVID, a lot of the rules use a cutoff of 1% to 2%. So in other words, if they're very, very unlikely, and if it was quantified less than 1% to 2%, we can actually exclude it clinically, and we don't have to worry about testing further. And that's what a pathway like the Wells and then going on to the PERC, for instance, allows us to do. If we just draw a line here, so up to our original pre-test probability, that brings us down to 2%. This is really then the portion of the patients that will benefit from this particular test. Because if we're saying that our acceptable risk is at 2%, if we start at 30% likelihood, or anywhere there, let's just say they're moderately likely to have the illness, even if it comes back negative, we're still above that threshold of 2%. So is there really any utility in doing this test in that patient? The answer is no. So just to show you here, that's the patient that really shouldn't be tested. This is the patient that would benefit from a D-dimer. That's why it's so important to risk stratify a patient with suspected thromboembolic disease before pulling a D-dimer. because someone that's considered high or intermediate risk falls into this group here, and even a negative D-dimer is not reliable enough, considering the risk that we find acceptable to exclude a PE. And the next step should be something like CTPA if we're going down that pathway. Just very quickly on negative and positive predictive values. They really take into context the prevalence or those pre-test characteristics. The problem with them is that if you're quoting a specific value for positive or negative predictive value, remember that that is specific to the population in which it was studied. All right. And we did mention that as prevalence goes up, positive predictive value becomes better. The opposite is true for negative predictive value, and we illustrated that a bit in our example earlier on. One last one here is likelihood ratios, another one you might come across. They're actually very nice instruments to utilize because you can apply them directly to a patient. In other words, they pre-test sort of setting and come out with a post-test indicator. So one is really neither here nor there, and you've got two markers, a positive likelihoods ratio. The further that goes up above one, the better that particular test. And for a negative likelihood ratio, so in other words, that if it comes back negative, it really means that they're unlikely to have the illness or disease. The further away that is from one and closer to zero, the better that is as a test. So the actual versus the process. So the actual is that the patient in front of you either absolutely has a disease or they absolutely do not. Unfortunately, we don't know what the case is. So we have to go through a process to try and delineate or try and assess what their diagnosis could be. And in most cases, this is working on probabilities. And hopefully some of those graphs earlier reflect that. There are certain instances where it seems almost certain 100%. Maybe someone who falls onto an outstretched hand and now has a fracture of the wrist, and you can see that on the x-ray. It doesn't seem like there's any doubt that there's a fracture there. And for all intents and purposes, we can take that as 100%. But on the most part, we're working with probabilities. Unfortunately, just like patients stress so much on action rather than inaction, they also see things as an absolute, as do many of us in certain circumstances. And they don't appreciate that there is this process behind the diagnostic pathway and behind the treatment pathway. So are we diagnosticians or probabilisticians? And that's, a term coined by Simon Cowley from St. Emlyn's. He's got a really nice little ebook covering a lot of this. So his thing is that we are probabilisticians rather than diagnosticians. We're working with probabilities. So a patient either has disease A or they do not. That's the absolute. We see it as a bit of a dichotomous process that will either confirm that they have disease A or will prove that they don't. But in reality, the outcomes are a little bit different, as this one, this little image indicates here. Could get false positives, false negatives, true positives, false positives. If we then incorporate treatment into this care pathway, this does get a bit busy, but I'll just highlight one or two principles. Are we then healers or are we pragmatists? So do we take into account all the information, and are we more realistic as to what the actual outcome might be, firstly from the test, and what the treatment might offer to that patient? So this is quite a straightforward view as, well, if he's got it, I'll treat it, and that's that. It'll help him. If he doesn't have it and I treat him, well, that's that. There's no benefit, but no harm done. But we know that that's not the reality. And this is a very busy one. For those that are interested, it's worthwhile just reading through it. It highlights things that I think we all already know, but that there are various outcomes to a positive test. Even if it's a true positive, it could be that the patient gets the treatment and benefits. It could be that they don't benefit at all. And it could be that they actually experience harm from that intervention. And we need to keep that in mind, that getting to the diagnosis doesn't always mean that the treatment will always benefit the patient. So when to test and when to treat. And we're going to get onto the more interesting stuff in a second. There are two thresholds that we innately prescribe to all the patients that we see, and that is the test threshold. So it's that level of risk at which we say, I don't think that they're that likely to have it, so I'm not going to test them and I'm not going to treat them. And we immediately dismiss that as a possible differential. And anyone that's above that sort of threshold, we will either test or possibly treat. And there are different things that affect that threshold, like severity of illness, the safety of the test, etc. On the opposite end of the spectrum, although not always that far apart, is our treatment threshold. So it's that level of likelihood of illness at which we say, I'm actually fairly certain that, or I'm comfortably certain that this patient has this illness, So I'm going to start treating and I don't need to test any further. And once again, the point at which if we were to give it a numerical value, we would find this threshold differs from provider to provider, from patient to patient, etc., taking into account various considerations. There's sometimes that testing really doesn't have any place, and that might be when there's just no available treatment. So an example in COVID might be a patient that you've decided, or the ethics committee has, in conjunction with yourself, decided is for palliation. If you're not going to treat a specific thing any further, there's really no utility in testing any further. So what is the available treatment, and will you do something with it? Okay, so now let's get on to the meat of this. We'll start off with a clinical sign. I know it says special investigations, but what we're going to do is look at various things that could be incorporated into our workup of a suspected or confirmed COVID. We'll just look at some of the details behind that particular test or investigation, its possible utility, and in our own practice, how often we're potentially using it, and perhaps just a bit of discussion around that. So ambulatory or exertional SATs. It hasn't been validated in the COVID-19 population as yet, but it has been quite extensively tested in terms of predicting clinical course of illness in COPD and interstitial lung disease patients with a 6-minute walk test. And there they use a cutoff of any change or a drop of more than 4% is significant. It's also been looked at in PCP, and the reason I included that is a lot of people have compared that clinical picture of what we've seen in COVID pneumonias to PCP or PJP pneumonias. So it was assessed quite some time ago in a PCP population. As I said, it's quite widely used. We're certainly utilizing this in our practice. It has been arbitrarily assigned a cutoff of 3 or more as a drop to be significant. There are various documented ways in which you can test it, but ultimately you're trying to stress the patient to some degree that's safe for them. So get them to walk up and down your unit a couple of times. So do about 30 meters or so. It's not for everyone. It's likely very specific. So in other words, it probably rules in a patient that's likely to need oxygen support in the near future, but not very sensitive. It's relatively safe if we employ it in the right patient, and that's what we'll look at right now. So what's its utility? As I say, it's potentially useful in assessing severity of illness or predicted severity, and therefore able to help us decide on disposition or management decisions. This might be used in someone who otherwise we weren't thinking of admitting, but now we do an ambulatory SATs on them, and we see that they actually drop by 5%. That's concerning, at least from what we've read so far. Once again, the evidence within COVID isn't great at all. It's actually non-existent other than anecdotal reports. So for that group of patient that looked otherwise well and isn't for admission, a possible screening tool, their SATs must be above 90, because as soon as they're less than 90, we're going to be admitting them anyway, and there's really no utility in performing an ambulatory SATs. And obviously they must be able to safely ambulate independently, because it's a safety concern. You'll see that as we go through the various things we're looking at, I have included the costs. Once again, it's certainly not the most important consideration, but it is something we need to take into account when we are assessing or working up our patients. So we use this in some of our patients. COVID swab. So this is something that's really been discussed extensively. We know it's a real-time PCR test, and there's a variety of assays. Not all the labs use the same ones. It depends on what sequence of the genome they're using. Variable sensitivities have been reported, and part of the problem with that is, as we mentioned earlier, there's just no gold standards to compare it to. They compare it to a lab environment where they know that the virus is present, and then test and find that it has a good sensitivity and specificity. But like we discussed earlier, there's a process to any testing pathway, and in the real life environment, it's turned out quite different, with reported sensitivities anywhere from 60 to 90%, and some actually even lower than 60%. The way that they get that, because we've said that this is the gold standard, so what do you compare it to, is they either compare it to other indirect signs of illness, like CT scan, for instance, or sequential testing. So they might have tested negative up front, and in the same illness, they'll test them again, and now it's positive. So then they then consider that first one a missed positive or a false negative. It's got a pretty good specificity, with most reports coming at about 95%. There are numerous pre-analytical variables. So in other words, there are numerous things that before that's even reaching the lab can affect how reliable it is as a test. You know, where is it collected? Was it nasopharyngeal, oropharyngeal, etc.? I know we're using pharyngeal swabs, but sputum has been looked at in certain trials and it's not nearly as sensitive. The quality of the sample, so the technique used when collecting it, the time in the illness course. Was it too early when they were asymptomatic? Or was it beyond the time that they were really experiencing a high viral load? And then severity of illness. It does seem that those with a higher severity of illness often have a higher viral load, and then they're more likely to obtain a positive test. The next big thing that we all know is that a positive swab does not equal infectivity, and that's part of the reason why the NICD has elected to have a non-testing de-isolation process, because the persistence of viral shedding can last anywhere 12 to 30 days on average for a mild illness. And there's some reports of it lasting as long as 9 weeks in more severe illness. But it doesn't relate to infectivity. As we've seen, the guidelines have been updated to 10 days of isolation. And that's because most of the studies looking at active virus or infective virus, where they culture it in a safe environment, they really find minimal growth beyond 9 days. That's most studies. So a positive swab does not equal infectivity. Just quickly plotted this on a leaf plot, just to highlight in case people are batting to conceptualize it. And when we're thinking of something like this, and once again, it's more qualitative description than assigning a specific likelihood when we are seeing a patient as to how likely it is they are COVID. Are they very likely? Do they seem quite likely? I'd be surprised if it's not. I wouldn't be surprised if it is, etc. And what the impact of a negative test actually means. And when we spoke about those test and treatment thresholds, what do we consider a treatment threshold for COVID? Especially a mild illness where the treatment involves isolation, it will have an impact on their work, obviously. But beyond that, there's certain interventions that we're using with minimal risk. So with such a relatively risk-free treatment and such a significant impact on public health, we probably have a very low treatment threshold. It's difficult to really quantify it numerically, but in our own minds. So just to highlight that, someone who you see almost certainly looks like a COVID, come from a COVID positive family, have been living with that family the whole time, now present with all the typical features, the same as you've seen in all the confirmed COVID positive patients. So they are very likely, 95% likely, but then they get a negative. It only takes them down to just below 80%. And speaking personally, I would say still well within the treatment threshold of patients with COVID. On the opposite end of the scale, how unlikely would we consider to not work someone up? And obviously, the current circumstances, we're surveying everyone that would meet possible criteria, as it's a public health issue. So therein lies the rub a bit. People a lot smarter, I think, than most of us that dictate the guidelines that are implemented internationally and locally still rely heavily on the positive COVID swab to really define what's concerned or confirmed COVID. On the ground level, that does seem a little bit funny because it looks like a duck, it quacks like a duck, it swims like a duck, it lives with other ducks, and yet we have to wait for an ornithologist to come and confirm it's a duck for us. And it's not that we've never seen a duck before. We live by the lake and we know very well what ducks are, what they do. So excuse the persistence of that analogy, but it does just seem a funny thing that there's still so much reliability on this COVID swab. But as I say, people far smarter than ourselves are still utilizing that as the prime way to define COVID. Okay, so moving on. It's an aerosol generating procedure. So for the provider, we obviously need to take the appropriate precautions. However, it's relatively safe, if not a little bit uncomfortable for the patient. Its utility, we said the primary is for surveillance. It does obviously have utility in diagnosis also. And in some high-risk patients, we would screen them. Like Netcare has that criteria out for the asymptomatic patient that might need to be screened. We're obviously using this in all of our patients at the moment. Put a little asterisk there. If there's time at the end, I'll just mention why I've done that. Okay, so other viral studies. So that would be the other swab that we maybe historically have taken, particularly in pediatric patients. Our pediatric colleagues seem to really like or consider these quite valuable studies. And they have different names. You might call it the multiplex or the core viral panel, the respiratory viral panel, or comprehensive panel. It's that swab that you normally send off, and you get quite a breakdown of the various viruses that they are looking for. It does differ from lab to lab. There's not one set panel that they'll use outside of a trade name like BioFire, which is its own machine and test. But it looks at typically 8 viruses, and a more comprehensive panel then breaks it down into subtypes and adds some of the atypical bacteria. And as I said, there's the BioFire trade name, machine, and test. It is similar to the comprehensive one up here. It does report very good specificities and sensitivities, but the fact is we're casting quite a wide net when you're testing for so many potential viruses and bacteria. So you invariably are going to be exposed to certain false positives and false negatives. And just like with the COVID swab, there are pre-testing problems with this. So before it even gets to the lab, there are things that can affect the reliability of the results. As I said, we are going to see it. One thing to take note of is we do see mixed viral infections quite often, even within that multiplex. I'm sure those of you that do utilize it have seen on more than one occasion that 2 or more viruses have been identified. And that can happen in up to 30% of cases. That includes COVID. The reported viral co-infections range anywhere from 6 to 30% in the different studies. So getting a multiplex and seeing that it's cultured, or sorry, that it's identified, that it's identified RSV is more than likely not sufficient to actively exclude COVID-19. Then you can get other co-infections like bacterial infections, which we see quite often in influenza. And often those co-infections go up with increasing severity of disease. And just like with the COVID swab, a positive result doesn't equal infectivity. I must tell you, I hardly ever use this, because how does it really change our management in the ED? Like we say, if we take into account that our primary goal is optimizing outcomes for our patient, is identifying that it's an RSV or other really going to change their management? And 99% of the time, the answer, at least for us, is no. Like I say, I know our pediatrician colleagues really like it. Its utility, that I have said in hospital as part of a pediatric workup, if that's what they'd like, may potentially affect our diagnosis and disposition. Spoken about in immunocompromised people, I do find that a bit questionable, because it says that they might not be showing the typical features of a bacterial infection. So if you identify a viral cause, or maybe that decreases the likelihood of a bacterial co-infection. But we've seen that is fairly common, especially with more severe illness. So I don't know if I'd hang my hat on that alone. The one patient that it potentially has a place in is the low to moderate risk PUI. So they're on that lower side of likelihood that they're a COVID. Their test comes back negative, so they're even less likely. And now you do identify another potential cause of their illness. Maybe that's a nice way to be comfortable that actually they really seem to be unlikely to be a COVID. We really use this very rarely in our practice. And surprisingly, a couple of big names in the EM foamed world actually still consider using this as part of their workup. As you can see, it's not a cheap affair. It can go all the way up to 4,000 Rand when utilizing the BioFire. There's a whole array of bloods that we've come across during COVID. I've just put in the prices there that you'll pay at most labs. There's some common lab abnormalities that we find in COVID. The important thing to note is that as an individual finding, they really lack any significant sensitivity or specificity. And once again, the whole picture or context needs to be taken into account. And there they might add some value in making a decision one way or the other. There are also possible indicators of severe disease. And I'm sure you see that a lot of them are in both. They're typical findings when they're not too significantly deviated from the normal. And as that difference from the norm increases, so there's a major increase or a major decrease, they then start to portend a severe disease trajectory. I think what's really important here is not noting these specific limits that have been put forward in some of the papers that have come out, and not to take away from what they're doing, But as a clinician, I find it far more useful to consider that the more extreme the difference or the more extreme the irregularity, the more sensitive it is that they either are having severe disease or are likely to experience severe disease. So the rational use of blood tests in COVID-19 for both suspected and confirmed patients is touching on what we went over at the beginning as part of our diagnosis, our prognostication. So we've touched on that before, but once again, taking into account the whole picture. We're not treating lab results, we're treating a patient. Obviously, you mustn't just put them to the side entirely if there's a significant abnormality, but we have to take it into consideration as part of the whole. Assessing for various complications, and we'll look at some of those in closer detail. So D-dimers, we're just going to look at one or two of the blood tests a bit more closely. We all have been exposed to D-dimers in the past. I think that historically, as we'll touch on, they are one of the most abused blood tests, as useful as they can be. The historical uses are primarily for thromboembolic disease, but they have been looked at in other entities like aortic dissection, dural venous thrombosis, mesenteric ischemia, etc. But by far the most common use is within thromboembolic disease. And like we know, they're a good rule out. They're not such a good rule in because they're so non-specific. And as I said, they're probably one of the most misused. I have put in there, query still is. We're going to probably head towards the greater utility of this test, whereas there are some experts that are actually questioning its utility in COVID itself and arguing against it. We'll just touch on that if there's time. So normal cutoff is 0.5. It does depend on what assay your lab is using. The other common assay is 0.25 or 0.255. Just need to know what's normal for your lab. There are, however, ways to adjust that. We've all seen, I'm sure in the past, you work up a patient, they get that a D-dimer of 0.57, and now you're inclined to get a CTPA. And how many of those actually come back positive? So various modification tools have been clinically verified that you can adjust that cutoff. There's age adjusted, where whatever the patient's age is the new cutoff. So if they're 67, your new cutoff will be 0.67. So obviously you've got no utility in anyone under 50. It doesn't decrease their cutoff. And then there are two other criteria, the years and the pegged, which I would advise you go and look at if you're not familiar with them. It allows us to increase that cutoff and therefore potentially avoid unnecessary investigations. And it really is a very useful blood test, but when used correctly, and like we looked at that leaf plot of D-dimers and PE, it's for that low risk cohort where it has a good negative predictive value. Just very quickly in the context of COVID, as I'm sure you've all seen, it's a common feature in our COVID patients that we see these elevated D-dimers. It's most likely related to this DIC-like state or COVID-associated coagulopathy. It differs somewhat to the typical DIC, which is consumptive in nature eventually, whereas the CAC, and that's why they've given it a new name, is more thrombotic in nature than consumptive. So in other words, it doesn't exhaust all of our coagulation factors and platelets, etc. One of the primary reasons I think this is happening, if you consider the Verschal's triad, is that endothelium is damaged, either directly by the virus or through other inflammatory mediators like interleukin-6, And we've seen as a consequence what seems like a significant increase in thromboembolic disease and arterial events in these patients. And arterial includes limb ischemia, large vessel strokes, MIs, etc. A lot of the papers use more than one as a cutoff to signify severity of illness. When prognosticating, a lot of them actually use above 2. But once again, I think that the take-home message is the higher and more deviated the result, the more likely it is that they're going to have a severe course. There's also something recently they looked at survival, so I'm going to hurry up, I've just seen the time. This is Jeff Klein, he's a well-known EM physician and editor-in-chief of Academic Emergency Medicine. They recently published a study that just looked at D-dimers and their negative result and what that suggests about survival. And you can see here that a negative result on day 1 had quite good survival odds, and a repeat on day 3 had very good survival odds. So it could also be used to prognosticate a good predicted clinical course. And he really feels, and he's really an expert when it comes to PE and D-dimer use, he really feels that D-dimer is one of the vital instruments in managing these patients. So how can we use it for prognostication, monitoring progress of disease, potentially for a diff, which we'll touch on just now about thromboembolic disease and its utility there still in these patients. And we use this in some of our patients. Not everyone, because not everyone needs bloods, and we'll touch on that also. Very quickly, procalcitonin, we know it's more specific than CRP regarding bacterial infections, but there are other causes that make it go up, like certain fungal infections, significant traumas, cancers, etc. It has been found to aid prognostication with a cutoff of 0.5. So once again, the greater the deviance from that and above, more likely the poor prognosis it portends. Keeping in mind that some experts say that when it goes above 10, you really should consider the possibility of a superimposed bacterial infection. The other utility, which I actually find more useful than prognostication, is potentially excluding a bacterial infection. One of our biggest concerns as a practice heading into this pandemic was missing our usual patients' diagnoses because we're so consumed with COVID. And of course, one of the primary differentials for these patients we've seen is potentially a community-acquired pneumonia. And if they're still in the workup phase, potentially getting a PCT of less than 0.25 has a very good negative predictive value in excluding bacterial infections in lower respiratory tract infections. Once again, it's not validated in a COVID cohort, but historically that has been validated in non-bacterial pneumonias. Just while we're touching on that, the presence of superimposed bacterial infection in confirmed positive patients isn't as high as was once thought, and more recent literature suggests it's actually closer to about 10% of hospitalized patients. So it's really not as high as we initially thought, and we use this in some of our patients. IL-6, it's quite a novel indicator to use in the ED, at least for myself anyway. It's not something I previously requested. Once again, it has various causes of an abnormal result, and it can be used in prognostication with various cutoffs being identified. And this one was actually found to be quite sensitive and specific for mortality when you get an IL-6. And I think it's most likely directly related to that cytokine storm that we find in patients experiencing severe and critical illness. And once again, we would use this in some of our patients. On VBG versus ABG, VBG really is preferable in most cases. Studies have shown that there's good correlation for most of the variables we get on there, with the proviso that it's a good quality sample. You're really not going to try and suck blood out of a little 22 gauge angiocath, getting a huge amount of air bubbles in there and expecting a reliable result. It does rely on a good quality sample. The things that don't really correlate are obviously the PaO2, but pulse oximetry is usually a suitable substitute for that, and that's in most cases. Even if it's dropping below 80%, and we know that it's not so specific anymore, it's still sensitive. So might show 65 on the pulse ox. In reality, the SATs in the blood might be at 45, but either way, they've got a severe hypoxemia. And unless you're wanting to quantify something like a PF, you don't really need it. A lactate above 2, once again, it loses its specificity, but its sensitivity is pretty good. It is most likely increased. We just don't know to what quantity. And then the CO2 above 45. So if we're worried about a hypercapnia, a VBG with a CO2 above 45 is not so reliable. We would then need to look at something like an ABG or an ETCO2 in someone with good cardiac output. And this was assessed in a COPD cohort. So when might we use an ABG? It's really hardly ever, actually. It's not that it doesn't have a place, but it's really is rare that we actually need an ABG over a VBG. And that's when we have an unreliable pulse ox. That could be for numerous reasons, including certain shock states, that they're so clapped out, they're just not getting that peripheral circulation, and ascertaining that high CO2, like I said. So ECG, myocardial injury defined as a leaking of troponins, identified on blood tests, so above the 14 of a high sensitivity trope, is fairly common with that reported incidence. And it could be for a number of different reasons. Dysrhythmias can either be directly from COVID itself or indirectly. They may be having electrolyte disturbances, there may be other metabolic disturbances, there may be other agents on board, etc. And it's just incidental that they're COVID positive. From a direct COVID effect, the most common dysrhythmias are sinus tachy, followed by certain atrial tachycardias like atrial flutter and AF, and then lastly VTACs. Myocarditis, it's still questionable, or certain experts question the actual likelihood that it's a true myocarditis, as it doesn't technically meet the definition, as there's no necrosis, if I remember correctly. Or sorry, there is necrosis, excuse me, but there's no inflammation within the cells. And inflammation takes place rather within the vessels. But nonetheless, we've seen myocarditis-like pictures in these patients. The changes are quite non-specific and can actually imitate other pathologies like ACS, etc. And if there's pericarditis accompanying the myocarditis, you can get the typical changes of a pericarditis on your ECG. ACS, the overall picture is that we actually see in decreased presentations, certainly in our practice, and that seems to be echoed in various practices around the world. There are various reasons why we think patients aren't coming into the hospital, but what we don't want to do is miss it. And a lot of these patients, there's an overlap of the type of patient that presents with suspected COVID and the type of patient that presents with suspected cardiac problems. There is also this likelihood that COVID does increase possible risk of ACS directly. And then PE, which we'll come to. And once again, great markers of PE on ECG. The most common finding is a normal ECG. After that, the most common is sinus tachycardia, with the most specific finding being T-wave inversions for your right precordial lead, so from V1 to V4, and your inferior leads. So that there would be your most specific finding in PE. PROS is non-invasive, and you can do it at the bedside with immediate results. It has variable sensitivities and specificities, though, and it is operator dependent. And the application of those sensitivities and specificities is therefore not universal. We have a high utility of it. It informs differentials, it looks for possible complications, and where patients are on certain medications, we can also watch the QTC. So we say in some of our patients, because once again, there'll be some that we discharge without any. Sorry, let me speed up. So imaging is not routinely indicated. So these are the recommendations from a group called the Fleischner Society. They're in a stark contrast to something like the American College of Radiology, who are quite conservative in their imaging recommendations. And I think part of the reason is that they're not really clinicians, not to sound disrespectful, but the radiologist assesses the films, whereas the clinician might be out front unless they're an interventional radiologist. So they see it from the point of reporting, perhaps, and not so much the point of the patient management. And the Fleischner Society have come with slightly more realistic recommendations, which you can read for yourself there, as to when we would image these patients. So chest X-ray is often the first line investigation, although they often come back negative, and anywhere from 20 to 60% in certain studies in ambulatory patients are reported as normal. And those are the typical findings that we can expect to find. They're most often the most extensive on day 10 to 12. Just to mention, I've put small pleural effusions in brackets here because pleural effusions really aren't common at all. And if they are present and they're not small, you've got to be considering something else. So they're the pros of a chest X-ray, which I think we're all aware of. The deep pathology refers to the difference between point of care ultrasound, which we'll look at next, which can scrutinize superficial pathology or pathology abutting the pleura. It can't scrutinize deep pathology that isn't abutting the pleura. It does have a relatively poor sensitivity and specificity, though. It does depend on where in the course of disease it's taken. Its utility, as stated there, so initial imaging utility very often, a modality very often to inform and direct the diagnosis and to get a baseline for a patient that's admitted in particular, to assess the severity and can potentially prognosticate. I won't go into too much detail about that. So we use this once again in some of our patients, all that meet certain criteria, which we'll get to. So point of care ultrasound is historically used for various reasons in patients that we would see in line with this, for a dyspnea workup, for line placement, for fluid status assessment, and for monitoring progress of disease. Those are the findings that are described in lung point of care ultrasound, and they are progressive in terms of severity of illness. There was a study that looked at the best findings in the ED that suggested a positive COVID, and bilateral B-lines as well as anosmia were the two most likely independent markers to suggest positive COVID. So that's bilateral B-lines and anosmia were found to be very reliable or very good findings to suggest a positive COVID in a patient. So I won't go into too much detail here. We can talk about it at the end if you'd like. One of the real figures within emergency ultrasound is an Italian by the name of Volpicelli. And his opinion is that he finds this most useful in the extremes of disease. So in the patient that really seems very well, he'll throw a probe on them. And if they've got no features of pulmonary disease, he's quite happy to discharge them because they don't have a pneumonia at that stage. And if they're very sick, he throws a probe on them. And if they don't have significant changes, he then starts considering other alternatives such as a PE. Cardiac POCUS, we can look for features of right ventricular strain associated to various causes within COVID. Can also assess global function and look for other complications associated with cardiac problems. And then a DVT POCUS, so just very quickly, it does seem to be this increase in DVTs, even in ambulatory patients. And when doing surveillance testing, rather than just going on symptoms, it goes as high as 69%. That does seem unlikely high, but some studies have found that in surveillance testing of just routinely checking on patients. And as high as 21% in ambulatory patients. CHEST, as a publication, the journal, sent out guidelines. They don't recommend routinely screening for DVT, but they do recommend keeping a very low threshold in which to perform the test. So if there's any concern at all, to consider looking for lower limb DVT. So POCUS, the pros are all those that are normally associated with POCUS, for those that are familiar with it. It's an immediate result at the bedside. It's readily repeatable, no radiation. Can decrease the stethoscope usage, which is important because whilst we can clean a steth, it is the action of bringing it up to our face that is a concern. And it can be more sensitive than chest X-ray, and in certain instances, maybe even than CT in the right hands. However, it is operator dependent, and infection control is a big concern right now. And it does bring the operator into great proximity to the patient for an extended period of time, which is important to consider. Can miss deep pathology, although most lung pathology in COVID is peripheral, and it's problematic in obese patients, etc. The other challenge is our in-hospital colleagues might not be as trusting of the findings as something like it. So that's the utility that we use it, and we actually use it in most of our patients. We're a very ultrasound pro practice. CT chest, I've just bolded the times when it's really most useful in our environment, and that's if we're concerned significantly about a differential or if there are complications. It really shouldn't be our first line in identifying these patients. It's got a good sensitivity, but poor specificity in the region of about 20 to 30%. Those are the typical findings. So that's what we've already said already, touched on. Obviously, it's the typical drawbacks of CT, the cost, radiation exposure, etc. And then there's a question of infection control for the departments. And we've touched that persistent patient, that patient who seems to have recovered from their COVID but has persistent functional impairment or hypoxia. It could be useful to further scrutinize their chest then. So we really use this for patients. Sorry, we're almost there. So this is quite a controversial topic right now, CTPA and when to image. So historically, CTPA, we consider the gold standard of diagnosing PE. But from the PIOPED 2 trial, which was conducted, I think, in 2006, it actually doesn't have as good a test characteristics, certainly, as I would have expected. It still means that we're missing a fair amount of PEs, and that it's not always that specific, which is surprising. What the PIOPED doesn't stipulate is if it incorporates subsegmental, which is important, and that's one of the drawbacks of testing too much, and we'll get to that now. There's also the question now of the validity of previous pathways in working up thromboembolic disease with things like PERC or Wells. Can we really utilize them in this cohort of patients? My personal feeling is certainly not the PERC, because one of the criteria to utilize a PERC or the PE ruler criteria is that there must be a low-risk patient. And it does seem that these are not low-risk patients. They are inherently a cohort that are prone to thromboembolic disease compared to the normal population. There's also been questions about the Wells, but as we go further along, I think utilizing the Wells in these patients is still fair enough, and I'll explain why as we go through now. The D-Lime is even less sensitive than it was before because it is so commonly elevated in COVID. And it was already used indiscriminately even prior to this pandemic. So that's the various incidences of PE that are reported in the various populations and the different studies. And what's interesting to see is that major society guidelines actually differ somewhat in how they suggest we work up thromboembolic disease, or more specifically PE, in this group of patients. So the American College of Cardiology and various Royal Colleges, as well as the British Thoracic Society, stipulate that we shouldn't rely on D-dimer alone because we are seeing it so often increased. We should keep a low threshold in which to test these patients for PE, so in other words, to move on to CTPA where feasible. And they advise that in patients where there is an unexpected or unexplained tachycardia or sudden change in condition relating to hypoxia, respiratory rate, or new chest pain, for example. Whereas the American Society of Hematology and a Dutch group whose work has been quite widely publicized actually say, consider doing a CTPA as you would have historically. So if the D-dimer is above the threshold, you've considered them a higher risk, you go on and you scan them. What they all seem to agree on, though, is that a negative D-dimer is still a good rule out. But I think that we do need to keep in mind that it has to be in the right cohort, and potentially that's where Wells can come in then. Not that they have other high-risk criteria that we just dismiss. We see that their D-dimer comes back low and we don't pursue it. Like we saw right at the beginning, that higher risk group, a negative D-dimer isn't reliable enough in order to exclude it at that time. So the pros of a CTPA is it's still considered the gold standard for PE diagnosis. We are potentially avoiding morbidity and mortality for the patient and for us having to explain ourselves in an M&M. The cons are quite a few though. Most of them are historical. The biggest one being incidentallomas, and that's this concept that although we are picking up so many more PEs than we did 25 years ago with the advent of CTPA, the overall mortality has not decreased in PE. So by picking up these potentially incidental PEs at a subsegmental level, or even more peripheral, predisposes them to treatment. It's not always a shared decision in discussing with the patient, as it should be with, in most cases, for these lower or more peripheral PEs. And then the risks of that treatment, so of the anticoagulants that they're started on. There's the radiation, etc., the costs and all of that. The experts within our practice, that's a couple of professors within emergency medicine, their feeling is that we should scan if the D-dimer is above the threshold. And that can be utilizing things like the age adjusted or the years. Once again, the various bodies are not in agreement on this. I think you need to find the right level of acceptable risk for yourself. Having thought about it quite a lot myself, I was initially of the thought that I would not scan routinely everyone that has a D-dimer that's elevated, especially during the surge, where accessing certain investigations was difficult. But as we've alluded to, we do need to consider the level of evidence on which we're relying at these times. And our previous pathways are quite heavily validated, whereas these new guidelines are often expert-based and there's no real validation behind them. And that includes using new thresholds for D-dimers, etc. Maybe they will become validated and it will find its use, but at the moment it's very much expert-based. Just a very quick example of a potential flow. This is what we utilize in our practice. And what I really want to highlight is that not every patient needs a workup. And I think that's especially important for our more junior colleagues, is that where there's an absence of these risk factors, it really pushes them to that lower likelihood of severity. What are we really gaining then from those investigations? Because are we potentially changing the outcome for that patient? And it's unlikely. So patients that meet a certain set of criteria can go through this pathway, be discharged and treated as an outpatient. The workup that we were historically doing as a guideline included that panel of bloods over there, as well as a portable chest x-ray. Going through this, I saw that we had actually left ECG off, as important as I said we find it. And as we are an ultrasound-focused practice, we do say consider POCUS. And we just extend that blood panel for our critically ill patients to that there. And we do say in both of our things is to remember the differential, because that's the part that investigations play also. Sorry, I know I've gone over time and I've got a bit rushed at the end, but are there any questions before we summarize or comments for discussion?
Thanks, Paul. I'll just to remind everybody, you can either raise your hand or type in the comments in the chat bar. There is one comment here from Anton De Vos. I'm not sure if you've seen it, Paul.
Let me just see how, sorry, how do I pull up chat? There we go. Good evening all. Hi, Johan. Session, sorry. Ferritin, troponin. Yeah, so, I don't know, Anton, I can only talk from my own personal experience. If anyone would like to pipe in, please feel free to do so. We were using ferritin historically. There were 1 or 2 studies that showed it had quite a good likelihood ratio in predicting severe disease. We used quite a high cutoff in our particular one, 700, where a lot used 300 or 400. For some reason, I don't know why, we seem to be moving more towards the interleukin. I think it's maybe just the trend at the moment and the relationship it has with the cytokine storm. The troponins we're really reserving for our more severe patients and those in whom we are concerned about cardiac involvement. Sputum, if we're worried about another pathology, we might send it off for MCNS, but a reminder that we don't induce. So it's only for those patients that are already producing. We certainly don't make it a routine that we send off sputum and MCNS unless it's a concern and part of your differential. TB testing, we often don't initiate, especially during this pandemic, within the ED. So I don't know if there's anyone else that's doing things differently. I don't know if that addresses what you were asking there, Anton. You know, just to comment, sorry, on something like the troponin, the reason we reserve it for that particular subgroup of patients is it is a highly sensitive troponin, but the trade-off then it becomes so non-specific. We know that there's so many different things that can cause an increase. So we really want to keep it in a focused population of patients to try and increase its utility. Any other questions or comments for discussion? Oh, sorry?
No, I was going to say, there doesn't seem to be anything else coming up. So,
okay, cool.
Maybe it goes off in summary then.
Yeah, thanks. Sorry, I know it's gotten quite late.
It's okay, thank you.
So in summary, excuse me. Oh, we're going the wrong way. Okay. Really what's vital to this whole process is, and we try and teach that to our junior doctors when they first join our practice, is before we initiate any form of investigation to ask yourself, will it change what I'm going to do for the patient ultimately? And will it ultimately benefit them? Because if the answer is no, we really got to think twice about pursuing it. Another way of thinking about it is, am I going to do anything about this result? So I keep on coming back to D-dimers, but we historically see a lot of our locums ordering D-dimers, it comes back positive and they don't do anything about it. You know, if you're not willing to follow through on it, don't pursue it in the first place. We really need to ascertain that we are relying on good quality evidence. And if we don't have the capacity to peruse that evidence ourselves, and there really is such an abundance of it, to at least go to a source that we know is reliable in scrutinizing it for us and giving us breakdowns, etc. And to find that right balance of being quick on the uptake of new things that seem trendy and not being adaptable at all. To know the strengths and weaknesses as well as the limitations of all the various tests, and then to apply them into the appropriate populations. And then to consider the use of guidelines. I know I really went over that quite quickly. A guideline, as opposed to a protocol, which is very rigid, it just really informs certain decisions. And is nice for a larger practice, especially when you are the one making the overall decisions clinically or in some sort of clinical lead position. So that's that. I apologize that it did go over, and I apologize for the shaky connection early on. But thank you again for giving me this opportunity. It's actually been a real honor. Thanks.
Thanks so much, Paul. I think that was actually an absolutely brilliant talk. So you have to apologize for going over. I see a few people have left, I think, with the time, but I think at least that we've got it recorded. People can watch it online as well. But that was a really, really good talk. Thank you so much.
Thanks. And
I won't open up for questions, but maybe if I can suggest that people can email me any questions they may have, and I can pass them on to you, or maybe they can reach out to you directly as well if they want to chat about something.
Sure.
But
yeah, they're more than welcome to.
Well.
And I saw there was a question about sharing the slide set. I'm more than happy to do that.
Perfect. All right. Cool. Thanks so much. Mandy, anything from your side?
No, thanks. It was absolutely brilliant, and I really appreciate it, Paul.
Thanks, Mandy. Thanks for the opportunity.
Pleasure. Bye-bye.
Cheers. Thanks, guys.
Have a good night, everybody.
Cheers.